Hello, everyone. Good afternoon, good evening, good morning, depending on where everyone's joining in from. My name is Jazz. I'll be one of the case discussants today. I hope everyone is doing well. I have the absolute pleasure of co-discussing today with Julia, which I'll hand over the mic to her to introduce herself to everyone.
Yeah, good morning, good afternoon, good night, and especially to Kashaya. Happy to have you around at night. My name is Julia. I'm a medical graduate from Germany, and it's it's definitely my pleasure to co-discuss with Jazz today. It's our first time. I'm looking forward to it a lot and very excited for the case.
Yeah, I'm excited as well. And let's hear from Hee Moon, who will be doing our teaching points today.
Yes, I'm Himun, and I'm very excited for Kashar, who's right now 2 a.m., right? Yeah, so excited for his case.
Awesome. And then I think Sasan will be filling in for scribing today. Sasan, do you want to unmute and say hello?
Hi everyone. I apologize for not opening my camera, but I'm not in a good space. But I'm excited for today's discussion and for Khashayar's case.
Awesome. And last but not least, Kashyar, who when we emailed him saying is 5:30 Eastern time a good time, he said yes. And then we found out it's 2:30 in the morning there.
Hi everyone. Yeah, 2 a.m. in the morning is fine, especially for a case discussion. This is a case that Alec gave me to present here, and it's really gonna be an exciting case.
We're looking forward to it, Kashyar, and I hope our discussion is good. It was good enough for you to stay up that late. So let's get the whiteboard up. I believe everyone should be co-host that need to be, and perfect. Kashyar, whenever you're ready, you can get started. And Julia, we'll start off with you as with the first aliquot, and we'll tag team from there on.
Amazing. So, this is the story of a 64-year-old patient who has had a 1 day of fever, body aches, weakness, and headache. She reports chills, fever with a temperature of 38 degrees, nausea, and diffuse body aches starting yesterday. She denies any cough, runny nose, abdominal pain, diarrhea, dysuria, or other symptoms. She describes the headache as band-like and denies any photo or phonophobia and does not have any history of headaches. In the ED, patient is hemodynamically stable, but then spiked a fever of 39.2 degrees. She was given Toradol, Tylenol, Reglan, and 500 cc bolus. She stated that antipyretics originally worked, but now the headache and chills have returned, and her symptoms are worse during the fevers, but they're overall tolerable. And I'm gonna stop there for the first aliquot.
What a great start. Thank you, Kashaya. So, um, when I start with this presentation, I'll try to focus on the first the host and also the time course. So here we have a 64-year-old patient presenting very acutely with 1 day of fever and like viral-like symptoms accompanying body ache, weakness, and headache. So, interestingly, when I have a um, or the symptom of fever, I'm looking if it's like the time curve, is it acute, subacute, or chronic fever, and also if there are any accompanying symptoms that can lead me to like a special course for this fever. Um, Here it's very unspecific, but we have hints for a systemic disease, so accompanying nausea and body aches. So we like to think in fevers, are there any like signs of infections? So other sources of infections in the hospital, there are mainly like skin infections, abdominal infection, respiratory tract, GI symptoms or urinary symptoms. These are like the main localizations we think about. We always have to keep malignancies in mind, but the time course wouldn't fit that well. Also, we think about like autoimmune causes, on drugs and endocrine causes. But here, because the time course is very acute, I would jump more towards like infections, especially viral infections, or like any drug reactions. So how I would make progress right now is to uh, do like a thorough physical exam, which we already started, and see if there are like any hints for a site of infection, and also dip in the medical history if there are like any reactions to like new drugs. Also, I would be interested in like any exposures in the like near surroundings of the patient, or also like travel history. I think that would be the first thing I would start with. Jess, what do you have in mind?
No, Julia, that was excellent. I don't really have much to like kind of add, but just what you were going through, I just wanted to label it for those who might not know the famous acronym by now. But IMAID is exactly what you went through: is infections, malignancies, autoimmunes, drugs, and endocrinopathies. But I agree with you with the time course. You would have to really be you would have to really convince me to think of anything else other than an infection right now. And I agree with you with the viral over bacterial. Now, Julia, just question for you. When we think of fever and we think of initial infection, the first thing is we want to ask ourselves, is there any localizing factors? And I don't see any. And that could be one of two reasons. Either Kashia wanted to stop there for us to discuss the fever, or there truly wasn't really a localizing factor. So let's say if it's the latter, what would you think you would have to rule out in this patient that doesn't really have a strong localizing factor here?
So, if there is no specific localizing factor, I would think about the most morbid causes that I have to rule out. And one thing I'm always having in mind is like sepsis or meningitis. These are two things that I would definitely want to rule out. I mean, taking blood cultures at this point, I think, is always the right thing to do. Accompany like especially, yeah, taking two pairs, that would be great, and also seeing if there are any signs of altered mental status that would lead me to like meningitis being the cause. I can also do like the tests, but they can also be falsely negative. So, but if I have any like hint for altered mental status, I would definitely evaluate if there if I do a CT and lumbar puncture to dive in.
Perfect. I'm not sure why you were nervous, Julia. You nailed it. So basically, if we don't see any, review system was negative, the only thing we have is a headache. And like you said, the physical exams findings for meningitis is not the greatest with the Kernizig and Berdinsky signs. So I would be concerned for a CNS involvement. And I agree with you, meningitis would not have confusion, but encephalitis would. And sometimes you can have a mixed picture of a meningoencephalitis. So I think it's too early to think about that, because this could easily just be a viral infection, like COVID or influenza, and it can explain this symptom. But considering we're here, we're at morning report, we do have to think a little bit deeper. And I think with the headache, the band-like headache, I wonder if that might be a clue for a possible localizing factor. But again, secondary headache from infection, just a generic infection, could also lead to that too. So excellent. I think we'll be very curious to see what the background of the patient is, because I think that will help us risk stratify this patient further, like if they're immunocompromised or if they had certain past medical history that may kind of tilt the needle one way or the other. So that being said, Kasia, let's hear the second aliquot.
Amazing discussion. Okay, I'm gonna give you guys some background on the patient. Her past medical history includes Holmes-Oddy syndrome, hypertension, hyperlipidemia, and type 2 diabetes with A1C of 6.6. She takes aspirin, atorvastatin, Celebrex, cyclobenzaprine, ergocalciferol, and lisinopril, metformin, and omeprazole. She has recently traveled to southwest Mexico 2 weeks ago, stayed in the city and went to the beach, ate local foods. She was in her usual state of her health until her return yesterday, and immediately upon returning home, presented to the ED. She notes multiple family members in Mexico having similar symptoms. And I'm gonna stop there.
It's getting more interesting here. So now what I've mainly take out of the second aliquot is that there is some pertinent past medical history here. So the diabetes, which is well controlled, and she takes medication for her like hypertension, hyperlipidemia. I am not aware what Holmes-Eddy syndrome is. Jess, you've definitely got to help me out here, but I would look that up. But I would maybe focus on the travel a little bit. So if she traveled to the south of Mexico, so there was probably a flight going on, that is always a risk factor for like any like pulmonary embolism or any like clot building, but that doesn't really fit to our symptoms here. She had local food, but also her symptoms are not like very fitting well to like any food poisoning. So I don't see that it helps me a lot. However, one other thing I was thinking about is like that the headache, or we can still not exclude that it's like an acute or the first start of a more subacute presentation. So in a 64-year-old with a headache and fevers, we can also think about like polymyalgia rheumatica as like one of the differentials, but I don't feel that this aliquot helps me a lot to narrow down my differentials, to be honest. Last thing, I'm thinking about like the drug reactions, but also it wouldn't help me a lot here, I think. No. So Jazz, help me out. What is Holmes-Eddy syndrome? Never heard of it.
Yeah, no, to be honest with you, the MVP goes to Parisa, who helped us out in the chat by saying it's a rare neurological disorder that affects the pupil of the eye. So how can we relate that to the current presentation? Honestly, to be honest with you, I'm gonna take a page out of Robbie's book is when you don't know something that's part of the past medical history, rather than fixating on it too much, focus on like how can we still explain what's the patient's here right now with, right? And right now, I agree with you that this past medical history doesn't really provide us information that says, okay, autoimmune is going up on the risk, because I still think this is infectious. Not to mention that she has a travel history, 2 weeks to Mexico. Now, that still doesn't really tilt the needle away from common viruses like COVID, influenza, and in her age, RSV. And then, it also doesn't completely kind of shut the door on certain common infections like Legionella, even strep pneumonia, because like she went on an airplane, she was around other people. The viruses and common bacterial causes for pneumonia are still pretty high. Now she doesn't have a cough, she doesn't have any shortness of breath, so I'll be curious to see what the physical exam is, but I would still be very curious because I wonder if those body aches or myalgia is secondary to rhabdo, which the most common bacterial cause of rhabdo is Legionella. So I would be very hesitant to move away from the common things until those are excluded. Now, to comment on the Holmes-Eddy syndrome, considering it's a pupillary defect, Julia, what's a pupillary defect that is associated with an infection that comes to mind? As a type 1 thinking. It's an infection, usually associated, we often think about it with the fever and rash.
So I'm not completely sure. Like you can have just like local infection from like pseudomonas, so from like taking baths, but like I'm not completely sure when it comes to pupillary
Yeah,
infections.
no. So syphilis is what I was thinking about.
Yeah, sure.
And like I'm not saying this lady has syphilis, but I from the further social history, she went to Mexico. Did she have multiple partners, or did she have a new partner? And just because she's 64 should not exclude the idea of having a sexually transmitted infection. So, and the other thing that points towards something that's more of a communicable disease here is that she had other family members in Mexico that had similar symptoms, which also suggests that could this is likely an infection. What type of infection? I think that will we'll start narrowing that down. But I guess to ask you, Julia, like what kind of I don't want to say exotic infections, but what kind of infections do you think about when it comes to travel to like a country that's a little bit on a warmer climate?
So we can always think about like a tick-borne disease or transmitting diseases that were transmitted by like mosquitoes. Um, I'm also I would think about infections that yeah, I think pretty much like infections that are transmitted by mosquitoes, so dengue, malaria, yellow fevers. Yeah, these are the first things that come to my mind.
Perfect. I agree with all of those. So that's just us narrowing, like kind of making an exhaustive list. But I think the fact that other family members are sick, I would say this is viral unless proven otherwise. But the other family members could just be a coincidence, and she may be having a separate process altogether. So with that, Kasia, I'd love to hear the next aliquot.
All right, so let's go to the physical exam and vitals. Her blood pressure was 121/62, with a pulse rate of 96, a respiratory rate of 24, a temperature of 36.8. This is later in the course, but as discussed, she kept having fevers. Uh, and a saturation of 96% on room air. She is awake and alert, lying in bed with ongoing fevers that, when present, she presents with Rigering at bedside. Uh, the rest of her exam is relatively normal, with no cervical LAD, clear lungs, heart having regular rhythm and rate with no abnormal sounds. Her abdomen is soft, non-distended, no rigidity or tenderness, or no rebound and no guarding. Her skin doesn't show any abnormal lesions on upper and lower extremities. Her MSK exam doesn't again show anything specific. No edema, no clubbing, no cyanosis. Pulses are palpated normally. She reports diffuse body aches, but there are no significant swelling, erythema, or tenderness elicited on the exam. Her neurologic exam is normal as well. And this is third aliquot.
Thank you for the great presentation, Kasia. So here in the physical examination, I think the most notable finding is that blood pressure, so the vitals are stable at the moment. Her heart rate is a little bit elevated, but like still in the normal limits. She sets 96% of on rumor, which is like still a little bit less than I would expect, but nothing very exciting. And apparently the fever is intermittent, or at least right now it's not present. That is something that could help me in the differential. But the most notable finding at all is like the rigors at bedside. So when I'm thinking about rigors, that could also be like just secondary to like an infection. So you can have like rigors in like associated to sepsis, but more like thinking about other infections that are that we were mentioning in the past. So with dengue and malaria, and even like rickettsial disease are associated to rigors, if I'm not wrong. So that kind of also let me lead more into like the acute infection side associated to her travels, but still very unspecific. Besides, I think since there are no rashes, that would also like lead me a little bit away from like tick-borne diseases like rickettsia or even typhoid, that would where I would associate it to like any kind of skin findings. And lastly, thinking about infections and skin lesions, also a pertinent negative that there are no like petechiae or any like bleeding that would hint to like any kind of like, yeah, for example, tick-borne disease where you would associate it to. So I think still very unspecific, but some pertinent negatives that like can help us, yeah, going further, I guess.
Excellent job, Julia. Quick question for you. So, have you heard of something called the Faget sign?
Yes.
Do you know
So,
what that stands for?
so from my understanding is that you generally have like in so there's certain disease where you would expect or a tachycardia is reduced, so you would expect the heart rate to be elevated, but it's um oh sorry so it's the association of the temperature elevation and the heart rate, and you would expect a higher heart rate, but it's not compensated because of it. I cannot explain it well.
No, you did great. Honestly, it was something that I had
It's
to
like, yeah.
go on.
Um, yeah, I was just like thinking about like the word of like the relative bradycardia. So it's, yeah,
Yeah,
lower
so
than you expected.
yeah, I would get confused all the time. So I try to simplify it for myself. Hopefully this is helpful. It's basically relative bradycardia, and how you want to remember is that for every degree Fahrenheit or Celsius rise, sorry, I think it's Celsius. For every degree of Celsius rise in temperature, you have approximately 10 beats per minute rise in your heart rate. Now, the thing, it's a couple of caveats. Patients should not be on a beta blocker and should not have any nodal disease. And if they do, then it's not as reliable, right? So, the reason why I mentioned that, Julia, is because I agree with your discussion that Rigers is very important here. Is this bacteremia? And we know that recent literature shows evidence that Rigers is actually more specific than just febriles for someone being bacteremic. Now, could this be possible that she picked up Legionella or strep pneumonia and now she's, bacteremic from that? Because that could explain why her family members are also sick. But this also says that this could also still be another atypical organism that was able to spread in a small, like a close quarter, and other people are sick. Then, if you put that into the equation and you use the pulse temperature dissociation, that does narrow the differential down to infectious etiologies. Legionella is still possible. It is one of the reasons. It's one of the etiologies that could do it. Typhoid, although Mexico may be less likely. Malaria, you mentioned that one, leptospirosis, you mentioned dengue. So, I think it helps us narrow it in a little bit. However, we also might find that given her age of 64, that she may also have some form of, bradycardia to begin with. Or, I looked at her list, it doesn't seem like she has metoprolol or any other beta blocker, so that seems less likely. But I think the thing would, I guess this is a question I don't know the answer to. I'm just wondering, do you think she's going to have a thrombocytopenia, or is she going to have a normal platelet count?
I would expect her to have a thrombocytopenia, even though I don't have any skin findings related to it. I feel the systemic features she carries. Let me lead towards like a thrombocytopenia because it's like generally associated with these kinds of infection. But that was just like my type 1 thinking that jumped to that conclusion.
Yeah, no, I actually agree that if we're really considering these atypical organisms and we're concerned of if this Faget sign is real, like it's something that we should be thinking a lot into. If we don't see a thrombocytopenia, I think that would be the great roadblock where we pause and say, okay, hold on, are we just missing something more common? And the Faget sign may have been like a red herring. So, anything else to add or discuss before we hear from Kashiar?
I think I'm very excited for the labs.
Yeah, I know. Spoken like a true internist.
All right, I love this discussion. Okay, let's give you guys some labs. So she had a white count of 1.5, a hemoglobin of 12, a platelet count of 111, HCT 36, MCV 81.3. Her sodium was 142, potassium of 3, creatinine of 0.4, BUN of 6 milligrams per deciliters, calcium of 7.1, glucose of 100, chlorine of 114, albumin of 2.8, total protein 4.5, AST 162, ALT 189, alkaline phosphatase 189, bilirubin of 0.8, PT, PTT, INR all normal with a bland UA. Her CK was normal. Her COVID flu testing was negative. Chest X-ray was unremarkable. And EKG was normal with normal sinus rhythm. I have one more aliquot before I give you the answer, and my main question after your discussion for this one is that what do you like to do next?
Thank you so much. You're presenting like a pro. Thank you. So I was excited for the labs, and I think there's a clue that helps me definitely. So what is striking is the white count of 1.5, if that's correct. So there's a marked leukopenia. And when I think about like the Rigers and the systemic feverish syndrome associated with like a low white count, I still have high on my differential like dengue fever, also yellow fever, also typhoid can do it. And I recently had read a case with like brucellosis, for example, but I think there's no like hepatosplenomegaly that I would expect. And also still what I think is very important to notice that there are no like rashes or no skin finding and also no signs of bleeding at the moment. So that is something I'm very concerned for generally. The other thing is that we have highly abnormal liver values. So the AST and LAT is elevated, but also the ALK phos. So that and albumin on the lower end as well. So here the alkaline phosphatase can either like come from the liver or from the bone, but in conjunction with like the elevated liver enzymes, I'd rather have it like an intrahepatic pattern of injury. So that is something that's very striking. Also notable is that the CK is normal. That's also yeah, that helps me a lot. And the platelets count is on the lower end. But help me out, Kasia. What is your reference range in your laboratory on for the platelets?
This is close to the lower range of normal, I
It's
think.
still normal, right? Yeah. Okay. So with like the liver injury and also the low white blood count, I would most likely be concerned that there's like a dengue fever or probably also like brucellosis is something I'm thinking about. So my next step would looking or doing immunologic testing for antibodies and PCRs for the named organisms. That would be my first step, and also looking at the blood smear. I think these are the next two steps I would have in mind. Jess, do you want to add your thoughts?
No, I think that you honestly like did a great job of discussing that, and I agree with you. I think dengue should be highest on the list. I guess one question I wanted to ask you is like the fact that this lady has a leukopenia, a thrombocytopenia, but a normal platelet count, oh, sorry, a normal hemoglobin count. Why does that support your theory of dengue? It's okay if you don't know the answer. Like this is a question that I feel like I recently learned. So this is a tough question, but I wanted to ask because I feel like you're right. I would be concerned in dengue for multiple reasons in this patient, but this is another clue from the labs.
When I'm not what I remember, if I remember it correctly, in dengue you distinguish the first infection and the second one, and generally the first one is not associated with a lot of hemolysis finding, but the second because your immune system get primed. So if that is the first encounter of dengue fever in this patient, I wouldn't expect the hemoglobin to drop markedly, I think.
Yeah, so you're not wrong in saying that, but I think that the point that I was trying to get across is that dengue virus is actually notorious for causing hemoconcentration in the sense of because in the setting of increased vascular permeability, right, and plasma leakage. And the other one that is notorious for causing that is hantavirus, but we know that this patient does not have any pulmonary effusions on the chest X-ray, plus the exam was normal too. So I think in this patient, I'm right there with you. I think this patient is not like this is what we talked about in the earlier alquad, right? Like is if the platelet count came back normal and the white count was more of a leukocytosis, I would be very like uh, not confused, but I would have to really cast doubt on the diagnosis of a viral infection like dengue. But I think this supports our theory. I guess what else could this be? I think chikungunya is also possible. But the thing that I would pause is that she mentioned diffuse body aches, but did not really mention severe arthralgia, which, if you remember, chikungunya is the one that presents with severe arthralgias, in addition to fevers. But it can also present with leukopenia and mild thrombocytopenia. Rickettsial infections, like you mentioned earlier, I guess is possible. especially with the headaches and the myalgias and the fevers and the elevated liver enzymes. But the chances of her getting it and then, her family members too, I think it's likely that, it's lower on my list, but it's still possible. And, I think the clues in this presentation is the mildly elevated LFTs, the mild hemoconcentration. Although I don't want to put too much weight on it, she could be mildly hemoconcentrated in a setting of maybe decreased PO intake. But I just felt that like the degree of her leukopenia, you know, and then, the hemoglobin of 12 made me think of that, if I'm thinking out loud here. So I think this is an interesting aliquot, and I agree, I'm there right there with you that I would be sending off dengue serology to see if this is possible. And someone in the chat mentioned leptospirosis. So I think that would be a great idea. And I, if the dengue comes back negative is something I would consider, but no AKI, no other conjunctivitis, nothing that would make me concerned for wheel syndrome. Usually the systemic imprint of leptospirosis presents with. So anything else to talk about, Julia, before cashier? Because I believe the next aliquot is the final diagnosis, but I wanted to see if you have any additional thoughts.
Yeah, I was primarily thinking about the lack of myalgias or and also arthralgias, and if that is something that I would also expect, and like bone pain in dengue fever, or if that is not a pertinent finding and doesn't really move us away. That was just one question I had in mind.
I mean, yeah, for sure. I think that is an atypical finding of it. So I just want to be clear. I think this is likely a viral syndrome. I think that I would actually, before I even send, to add to your point, before I send off a dengue, I would actually send an atypical viral panel in this patient, and just kind of make sure that we're not missing like a common atypical virus. So that'll be the first and foremost. I think with the leukopenia, with the thrombocytopenia, we're dealing with a virus, like especially a virus that's notorious for causing some like leukopenia is also parvovirus, but usually presents with pancytopenia, which we don't see here. So I think that's why I'm kind of anchoring a little bit on the hemoglobin being normal. But I think if we're not gonna have to select one virus, I think it's going to be an atypical infection. However, to answer Kashia's question directly, I would still want to get blood cultures, and I agree with your idea of looking at the smear, Julia, just to make sure that we're not missing a parasite like malaria in this situation. And the other thing is the capillary leak of the albumin of 2.8. I'm curious if this patient did have some mild pitting edema or anything like that. So, but I'm willing to learn. I don't know what the final diagnosis is, but I would be surprised to see if it wasn't an atypical infection, specifically a virus.
All right. So this is not the final diagnosis. I'm gonna give you the final set of labs, and then I'll reveal the diagnosis after the discussion for them. And the peripheral smear showed that there is a microcytic normochromic anemia without significant anisopoikilocytosis. Schistocytes are not increased. White blood cells are decreased, but morphologically unremarkable. Platelets are decreased, but with unremarkable morphology, and no clumping or satellitism is seen. Blood cultures negative, HIV testing negative, hepatitis A, B, C testing negative, monospot testing negative, malaria antigen negative, no parasites seen on the peripheral smear, CMV IgM serum negative, a spotted fever group IgG and IgM negative. Abdominal ultrasound within normal limits without any specific abnormalities.
All right. So we have another great presentation of pertinent negatives, I feel. So I'm relieved that the blood cultures didn't grow anything. I mean, sometimes we have to keep in mind that some atypical bacteria needs more time, so we should definitely check on the results later and also maybe take a second pair. HIV is negative, that's good, and also like any hepatic infections, like for hepatitis, is not present. So we did not test for like sorry, we didn't send the dengue serology yet, so that was something we had on the list high up, but there's no malaria present. I am not sure how I can make much progress with that one, Jess. I think you need to help me out.
No, I think you're right there, Julia. So I think, okay, so when we're in this, let's compare and contrast here, right? So I think we still feel strongly this could be dengue or chikungunya, right? So classic presentation of dengue. You mentioned last time the thing that would be atypical is the break bone fever. We don't really get any of that evidence so far. By the way, Kashar, do we know if the platelets continue to downtrend or did they stay stable in the hundreds?
I don't have any information on that,
Okay.
whether
And do you
they
have
trended or not.
Okay. Do you happen to know if the fevers were pretty persistent or did they like, kind of bottomed out pretty quickly?
The fevers initially before coming to the ED responded to antipyretic therapy, but during her hospitalization, there was no response to them, and they kept coming and going.
Okay. So I think, Julia, like the other thing that we didn't talk about, but I think would be important to highlight is this lady has a history of hypertension and does take, lisinopril. But here she has a blood pressure of 121/62, which does, put me in more risk or like more concern for a capillary leak. But one thing that she does not have that typically dengue does present with is retroorbital headache, because the one she presented was band-like, right? Which makes me think of a tension headache. Retroorbital will be right behind the eye, and it's usually pretty severe. But it could also been misclassified, or it could have been kind of, an atypical headache presentation. Dengue doesn't typically present or doesn't always have to present with a rash, but chikungunya does have it often macular papular rash. They both can present with thrombocytopenia and leukopenia, but the reason why I was asking about the platelet trend is usually with dengue, the thrombocytopenia is a little bit more like pronounced, whereas chikungunya is mildly thrombocytopenic. They both can lead to transaminitis. So I think it'd be hard to kind of really pinpoint. And I honestly, the other question I would love to ask in real time is what did they do in Mexico exactly? I know I saw that they went to the beach and ate local foods, but like, did they all do that as a group? And did they all notice some mosquito bites? Because why is everyone presenting with those symptoms, right? And did they all notice as a group that they had some mosquito bites? Then that makes sense. But if not, then I would say that was a piece in the history that we probably didn't have to focus too much on. But I think because of the hemoconcentration, lack of arthralgias, high fevers, this potential headache, that may or may not be retroorbital, leukopenia and thrombocytopenia. I think dengue slightly more favorable chikungunya, but it's like trying to pick between two, atypical viruses. But what's reassuring is blood cultures are negative, right? There's no chest X-ray finding of pneumonia. EKGs looks good. Abdominal ultrasound, I'm assuming, was done to make sure that the liver parenchyma was fine with those mild LFTs, right? There was no abscess sitting in there. There was no splenomegaly, which EBV or some atypical fungal organisms could have brought that up to the attention. Peripheral smear was good. Did not show any, abnormal like red blood cells or parasites or inclusion bodies. So I think the more and more we are looking at this, I think our confidence meter should go a little bit higher with that this is still a viral process. And if we had to pick one or two, I would say dengue or chikungunya. But Julia, if there's something that came into your mind that you wanted to share, I would love to hear it.
I am amazed how you organize and articulate your thoughts, Jess. I learn a lot always when you go through these cases. I'm pretty much on your side. I think it's not a very typical presentation. I just saw one case of dengue, so I'm not completely sure, but I would probably be prone to jump more to dengue fevers, but because of the lack of the myalgias. But that would be, yeah, that would be the thought I have.
Yeah, and I think two things. One is if this turns out not to be a viral or atypical organism, I'm gonna like go eat my pint of ice cream to soothe my emotional pain. But two, I would love to learn like where I would love to do a cognitive autopsy if this was not one of the things that we talked about, because I think everything that we've analyzed together, Julia, is it looks more and more like that into that bucket, especially what we've learned about it. But so I would love to see if it's not like what could we have done, what could we have discussed differently. So I'd love to hear from Kashier.
I have loved this discussion so far. I'm learning even though I'm like present in the case. So, for the final diagnosis, on additional history, she reported her and her family were bit frequently by mosquitoes, and dengue fever IgG returned positive at 12.84, with IgM being negative. She improved with supportive care and time. Her labs returned to baseline at her follow-up visit 1 week after discharge.
Julia, what are your thoughts?
That was such an interesting case and discussion. I'm very grateful, Kasia, that you took all the effort to present it in that way, and it left a lot of space for discussions and reflections. Um, I think what my main takeaway here is really how the history can help us to make a lot of progress so that the whole family was affected, but also like the teaching point that there is not a pancytopenia present, but really like this hint of for a capillary leak, not only in the normal hemoglobin, but also in the low albumin. That would be like a kind of hint either for it could be just a production issue and like liver disease, but giving this presentation, it's more likely to be a sign of capillary leak. That was really the key clue that helped us out to narrow the differential down. So there's definitely a lot to revisit and reflect on, but amazing case. Thank you so much.
And Julia, I think, sure, I think we all can always reflect on our discussions and cases, but truly, you had nothing to be nervous about. You said dengue, I think, after the second aliquot. So I think But I think what this case really highlights is how beautiful medicine is, right? Like the main thing that stood out is the Faget sign, right? On the vitals. That was my teaching point. Like that's something that I feel like that was important. And then the fact that this lady was not pancytopenic, where the other two cell lines were down, is like the question is why? Is as simple as dehydration, but the leukopenia was out of proportion to, I would have said, just dehydration or decreased PO intake. So I think that's where we had our clues that this is possible dengue. But Julia, you did a fantastic job. Truly didn't really even need me. So also, I just want to, before we give it to Hee Moon to do the teaching points, I love how she wrote family all bitten by mosquito kisses. I'm gonna take that from now on. Hee Moon, it's all yours.
Yes, thank you so much for a wonderful discussion, Julia and Jazz. And Sasan, thank you for subscribing. Okay, so 64-year-old female with 1 day of fever, body ache, weakness. We were considering acute versus chronic. It's acute. So we consider a viral, and then we used I-made pneumonic. And then Julia mentioned about possibility of bacteremia like UTI, URI, GI, biliary, unknown sources. And we have to look at vital sign and physical exam because patient was having headache, considered meningitis, and also travel history to Mexico, considered TB, Legionella, but those are less likely due to no cough and shortness of breath. So Julia mentioned about tick and dengue, malaria, and family also had a similar symptoms. So consider viral infection and also auditory pupil defect of family, past medical history. We have to also consider the syphilis. And the physical exam, patient was showing the rigor, which is the sign of infection like bacteremia, sepsis, malaria, and rickettsia infection. So look for skin petechia, thrombocytopenia. And the Fajr sign, patient was having heart rate, which is not as high as high fever. We could have seen in typhoid fever, dengue, and Legionella. And also consider whether patient is using the beta blocker. And the lab is showing the normal hemoglobin, and it could be capillary defect due to hemo concentration, and also thrombocytopenia, leukopenia, liver enzyme abnormalities is pointing to dengue. And we can consider another like hantavirus, chikungunya, rickettsia, leptospirosis, but less likely without eye and renal dysfunctions. And we have to look at serology, PCR, blood culture, including atypical and viral infection also. And then just mentioned about retroorbital headache in dengue without rash is possible. And chikungunya is rash is prominent, and thrombocytopenia is more pronounced in dengue rather than chikungunya. And then all family was affected, so I wrote the family all bitten by a mosquito kiss. So be careful on mosquito when you travel. Thank you so much.
Amazing teaching points, Himun. Kashiar, thank you again for such great presentation and such great eloquence. I know that took some time. Sasan, you did an amazing job of scribing. And Julia, it was a fantastic time dancing with you today. You all have a great Tuesday. Bye.